cord to this computer. All right, we are now recording.
Okay. And can you see the slides moving?
Yes, we can.
Yes.
Okay. Thank you, Alan, and thank you everybody for joining us today. I will try to provide a perspective anyway on in vitro gametogenesis and perhaps how it may at some point interface with IVF. I don't have to tell this audience that in 2028, we will be celebrating the 50th anniversary of IVF with the first announcement having come on the pages of the Lancet by Steptoe and Edwards back in 1978. And of course, that report was all about the birth of Louise Joy Brown, and the leading principals being, among others, of course, Bob Edwards. Now, it turns out that only Bob Edwards received the Nobel Prize in 2010, and you may wonder why. The reason, unfortunately, is that the two main collaborators, Patrick Steptoe and Jean Purdy, were no longer with us at the time. And it is a policy of the Nobel Prize Committee to award the prize only to living recipient. And so it was Bob Edwards, who was the sole survivor at that point, who received the Nobel Prize. I might add that Bob Edwards wasn't well at the time, and in fact, it was his wife who flew to Stockholm to receive the award on his behalf. Finally, the Lancet published an obituary of Bob Edwards in 2013. In the US, as you doubtlessly know, the first IVF pregnancy was the byproduct of the so-called Norfolk team, shown here. On December 28, 1981, the Norfolk team accomplished the delivery of their first baby. And that, of course, was Elizabeth Jordan Carr, who, as you know, is a Bostonian, and who was the first American IVF baby. She was, of course, displayed on every potential media outlet. The Boston Globe was one, Life magazine was another, and there was, of course, a slew of others that celebrated what was a remarkable achievement at the time. But going forward, it seems that the focus and interest is now primarily on in vitro gametogenesis. And I'll try to do justice to the concept and to the state of the art, if you will. Before we do, however, we would probably do well to remember Aldous Huxley and his famous book, Brave New World, from 1932, where he made three key predictions. He stated that eggs will be produced via ex vivo ovarian cultures, that embryos will be produced via in vitro fertilization, and that newborns will be born via ex vivo ectogenesis, which we are clearly nowhere near yet. Now, in hindsight, obviously, Mr. Huxley was perfectly correct on predicting that embryos will be born via in vitro fertilization, but he really could not have foreseen IVG at the time. Nevertheless, the director of hatcheries and conditioning in the Brave New World says at one point, one egg, one embryo, one adult normality, making 96 human beings grow where only one grew before progress. And that's another way of characterizing IVG, which definitely can produce a limitless number of gametes for our use. The beginning, as always, was modest, but it's important to note that the beginning is traceable to two leading Japanese investigators who continue in many ways to lead the field. I became aware of this field somewhere in 2013 or 2015, and in a trip I made to Japan for another reason, knowing that this was going on, I booked a flight to Kyoto and spent half a day or more speaking to these two gentlemen about IVG at a time when it was not yet widely recognized. The two individuals in question are Mitinori Saito, who was and remains at Kyoto University. He's a full professor and a remarkable investigator. He's postdoc at the time, but now an independent investigator at Kyushu University, was Katsuhiko Hayashi, PhD, another brilliant individual who has since made significant contribution, particularly with respect to same-sex reproduction, which is a different topic and perhaps we can talk about another time. The whole premise of IVG, though, rests on pluripotent stem cells. Now, when I say stem cells, it's important to know that they come in two varieties. One is known as embryonic, and the other as induced. Stem cells have now given rise to motor neurons, to amacrine neurons in the retina, and to dopaminergic neurons in the striatum. It's quite amazing. And not only that, when you apply these stem cell-derived lineages to appropriate patients, cure can actually be accomplished. Here are some examples. An individual who was paralyzed was able to walk again upon receiving stem cell injections into his spine. An individual with Parkinson's disease has shown significant improvement when injected with stem cells into the striatum. And of course, we are more interested in gametes, as we should be, and that's an area that's moving forward, although perhaps as we speak, it is not quite there yet. Science magazine was very cognizant of what was happening, and in 2021, it dedicated a full spread to in vitro gametogenesis, with the two leading protagonists at the time, Dr. Saito and Dr. Hayashi. The New England Journal of Medicine, not to be outdone, likely commissioned a paper from Mary Herbert and Azim Surani from the UK and published a similar paper titled Oocytes from Stem Cells. In 2023, I had the privilege of organizing a 2.5-day workshop under the auspices of the National Academy of Medicine. And that 2.5-day meeting dealt strictly with in vitro-derived human gametes as a reproductive technology. You might also want to note that the Nuffield Council on Bioethics, which is the primary ethical body of the United Kingdom, when it determines the kinds of subjects it will deal with in human reproduction, it put in vitro derived gametes at the top of the list. Yes, they'll be dealing with several other topics that you can see. But at the top of the list was in vitro gametogenesis. I don't think we will have any trouble agreeing that in vitro gametogenesis is a disruptive technology. Whether or not it's achievable in the human remains to be seen. And the timeline thereof is similarly uncertain at this time. But to understand IVG, I have to come back yet again to the formation of pluripotent stem cells and the technologies that underlie it. The first technology that produced somatic cell nuclear transfer was really dated 1958 and was spearheaded by John Garden from Cambridge University, who published on the pages of Nature an experiment which started with a somatic carioplast, which was transmitted or infected or transfected into an oocytic cytoplasm, that is to say, an enucleated oocyte, and gave rise to what we might call a zygote, which gave rise to a blastocyst, inner cell mass, etc., from which he derived embryonic stem cells. So this is the one variety of stem cells that dates back to 1958, but is not commonly used today. The more commonly used variety was originated in 2006 by Shinya Yamanaka, also from Kyoto University, in a Cell paper. This technology, which in some ways could be viewed as simpler, involves the transfection of somatic cell with select transcription factors, which gives rise to what we call induced pluripotent stem cells. Nevertheless, both individuals were appropriately honored in 2012 by the Nobel Prize in Physiology and Medicine. In vitro gametogenesis, as it relates to this area, involves starting with the somatic cell, let's say a skin cell, converting it either to an embryonic or induced pluripotent stem cells, more likely an induced pluripotent stem cell, and then guiding that stem cell towards a gametogenic fate. Now that's easier said than done. What are the prerequisites? Well, you have to know what cues to apply. You have to know the sequence by which they are applied. You have to know the timing of the application. And you have to be aware of the niche in which these cells reside. After all, I don't need to tell this audience that granulosa cells are surrounded by theca cells, and that in sperm, on the other hand, are surrounded by Sertoli cells. So oocytes are surrounded by granulosa and theca cells, and sperm are surrounded by Sertoli cells. And that's the so-called niche. Well, the beginning of the story, which, as I mentioned, is really in Japan, was also recognized by some European investigators and American investigators as far back as 2003. This paper, which is a very early approximation of IVG, shows an image on the right lower hand corner of a mouse embryonic stem cell This was a science paper senior authored by Hans Schroeder, who was then a postdoc at the University of Pennsylvania, but now is the director of a Max Planck Institute for Molecular Biomedicine in Germany. That same year, Toshiaki Noche, on the pages of the Proceedings of the National Academy of Science, published a similar paper. And George Daly, who is now the dean of Harvard Medical School, published in Nature in 2004 on the derivation of embryonic germ cells and male gametes from embryonic stem cells. René Rehopera, who was then at UCSF, published a similar paper. And as we go through the 2000 to 2010 period and the 2010-2020 period, several papers see press intermittently reminding us that the field of in vitro gametogenesis was slowly but surely progressing. And so when we try to summarize the state of the art in 2015, we can say that the germ cell specification pathway is probably not conserved between the rodent and the human, meaning that lessons learned in the rodent may not entirely apply to the human. And the genetic network involved may well be quite distinct as well. And so as we look at the state of the art in 2015, we can say that embryonic stem cells or induced pluripotent stem cells could definitely be converted into primordial germ cell-like cells. What we didn't really know how to do at the time is to take the latter and convert them to haploid post-meiotic mature gametes. In a word, we mastered the extragonadal component, and we had yet to master the intragonadal counterpart. The final frontier was really in vitro gametogenesis all the way. In the rodent, this has now been accomplished. Now, on the female side, in the rodent, that accomplishment goes to Katsuhiko Hayashi, who by now I think you're quite familiar with, who in 2016, if you recall, the ASRM was at the time in Salt Lake City. Just about that time, he published a Nature paper titled Reconstitution in Vitro of the Entire Cycle of the Mouse-Female Germline, and really made it happen, at least for the rodent. He started with stem cells, combined them with gonadal somatic cells, produced primary oocytes, then M2 oocytes, fertilized eggs, ultimately blastocysts, and lo and behold, he produced pups. In a word, you could take the in vitro gametogenesis cycle all the way, in this case in the rodent female, from a stem cell to pups. And our hope, of course, is that some of the same could be accomplished one fine day in the human. More of the same was true on the male side. The contributor in this case was Mitinori Saito, who on the pages of Cell Stem Cell reported the in vitro reconstitution of the whole male germ cell development from mouse pluripotent stem cells. So you could say that the story is complete as far as the rodent goes. The challenge, of course, for us is that we're not quite there yet with the human. And I want to show you how far we have come with the human, but to also point out that we still have a ways to go. Probably the furthest we have come in the human is illustrated in a science paper in 2018, senior authored by Mitinori Saito. As you might expect, it starts with human primordial germ cell-like cells, combines them with somatic xenogenic ovarian cells, and then proceeds with in vitro gametogenesis, if you will, but is only able to take the process to the ogonial stage. He is unable to produce M2 oocytes, and to this day, we have yet to get there. And so it seems like we are close, but no cigar quite as yet. If and when we finally cross that Rubicon, the scientific and translational promise is likely to be substantial. For one, we will have an inexhaustible supply of germ cells. Scientists could do null mutant analysis to their heart delight. We could embark on meaningful studies of germ-somatic cell interactions, which we are hard-pressed to do today. On the clinical end of things, we could potentially reverse germ cell failure. We could engage in autologous gamete replacement. We potentially could engage in gene-edited gamete replacement. And we could also arrive at same-sex parenthood, which, as I said, is an evolving arena which perhaps we can discuss another time. But it was made possible by in vitro gametogenesis. The impact on IVF, which has yet to be realized, is that IVG will eliminate the need in stimulation and, for that matter, egg retrieval. It will do away with gamete donation, and the age element will be less of an issue. It will, in many ways, convert IVF to a laboratory procedure. It will still require endometrial preparation and transfer, but it could, in principle, improve affordability and thus access. I say this with a question mark at the end because, having seen similar examples transpire in the past, I have also learned to appreciate the American genius in jacking up prices and really seeing to their reduction. Ultimately, of course, all of this will be subject to regulation and will come under FDA jurisdiction. At the FDA, the Center for Biologics Evaluation and Research will be the entity that will ultimately evaluate IVG, and it will probably assign it to an entity it calls HCTPs, or human cells, tissues, and products. I should say that we're not quite there yet. Now, as somebody already mentioned, there are commercial US efforts underway that have to still be realized, and more importantly, have to be FDA approved. I'm referring to the efforts of the company called Gamito, which I believe is New York-based, and its product, Fertilo, which is shown here. As the title suggests, Fertilo is the first induced pluripotent stem cell-based therapy to enter US phase 3 clinical trial. By that I mean it received FDA approval to proceed with phase 3 clinical trials. Of course, they have to go to phase 2 and phase 1, etc., but it's a start. Drawing on some infomercial, if you will, from the Fertilo website, they are proposing to make IVF and egg freezing shorter, safer, and more effective. And they compare conventional IVF with Fertilo, suggesting that 12 days of stimulation may become 3 days of stimulation. Fertilo cycles requires 2-3 days of in vivo gonadotropic stimulation, thereby presumably reducing the gonadotropic requirement by circa 80%. Fertilo's ovarian support cells see to the in vitro maturation of retrieved immature eggs. And Fertilo, as I said, is now in phase 3 clinical trials. So we are really in a wait and see mode. So I would say at this point, stay tuned. IVF still reigns supreme and will for a long time. But somewhere down the line, slowly but surely, perhaps in 10, 20, maybe more years, IVG will become part of our reality. And it may be a good thing for us to start to acquaint ourselves with this potential future therapy, the application of which at this time is still a vision rather than a reality. So with that, I hope I can stop here. If there are any questions, I'll do my very best to respond. Although, as I pointed out, there are numerous unknowns and uncertainties that are difficult to do justice to other than conjecture. So with that, I'm going to close. Alan, thank you for the opportunity. Hope that I have been of some service.
So much. Very nice. We can open the floor for questions. Anybody from the Zoom audience as well? Well, I have a question. So, we're concerned about access to care and, your comment about the costs of care. And, the societal implications, obviously, this could really open things up to a wide variety of people and make it much more democratized on the one hand. On the other hand, if it is limited to those with only extreme means, it could do just the opposite. If you had to, your conjecture at this point, which direction do you think? Do you think that the public sentiment will be to pressure the field into making this more available, or will this just become another exclusive tool in the domain of those who already have so much?
As I think I tried to intimate, my bias is that this will not change the economic structure all that much. It'll be yet another new technology that will be highly touted and will probably be highly sought after simply because it may offer some advantages. And so if I'm still around and I can confirm or not or deny whatever happens, if I had to project, I would say the American genius will prevail again, and see to it that the cost is hardly insignificant.
Eli, the cost is actually interesting because it's currently taking over 50 days to get an oocyte from a stem cell. So that means for 50 days, you're going to be treating that, well, just to get to the oocyte, not
Right.
the IVF part. So probably over 2 months, you're going to have gametes, if you want, from a patient in a lab. So that cost of keeping oocytes or growing oocyte stem cells in a laboratory is going to be quite significant, because that's, if you're doing 10 patients, that's 600 days worth of treatment you're doing for a patient, for 10 patients. So even now, the cost of the laboratory is actually one of the highest prohibitory factors for an IVF cycle. So sometimes I find it hard to work out the models for these, how it will actually translate to a less expensive treatment.
Yeah.
think
No,
also,
point very well taken. I think point very well made and point very well taken. I think it may be that the main cost element will in fact be laboratory based, but as far as the patient is concerned, the price is the price, and how it's arrived at is secondary. So your points, I think, are sound and could well materialize just the way you articulated them.
I think from a throughput standpoint and from an access of care standpoint, I think also one thing that needs to be considered is these egg retrievals are much more difficult with immature eggs. And so the OR costs and the time in the OR is also going to be an issue. So you're going to need a ton more time in the OR essentially to perform these procedures as well. They're not a simple, large follicle, simple egg retrieval. These typically take a longer period of time and require much more skill of the operator as well.
No, I couldn't agree more. I think this is yet another fine point that highlights the yet to be realized complexity of this approach and consequently the costs involved. So point very well taken, and no arguments for me.
It does set up the idea, though, of scale, depending on what the source cell is. If it's a source gamete, you have to go to the gametes to start them. If it's immature, just maturing it. But if you're starting with a buccal smear, you could have collection centers everywhere and have a big centralized automated lab in Evansville, Indiana, where the only thing cheaper than 1 acre of land is 2 acres of land. And set it. Sorry, Dan. If Dan Dan Griffin is on the line. I used Evansville specifically, not Newburgh, but Evansville. But so you can have centralized labs, you can have automated things of that nature, where it's kind of these long-term cell processing units overall. If there's long-term storage facilities, why not long-term culture facilities as well? Again, that's where automation and technology. But yeah, I'm always skeptical when people say, "Oh, it's going to it'll all just bring the cost down." I've not seen many examples where costs tend to be driven down.
It could change the donor oocyte model. We're talking many, many years down the track, but if you can create oocytes from some sort of induced pluripotent stem cell or stem cells, it may actually change the ability to generate donor oocytes if they're functional.
Although you'd have to make sure that you maintain diversity within.
Yeah.
So you'd have to have lots.
Eli, you made a comment about American ingenuity, but I wonder if you have a thought. I can just imagine the requirement for the FDA just on the safety of this.
Oh, yes.
What's the likelihood of it being done in another country like Japan or elsewhere versus the US? Because I could just see the hurdles of being unbelievably difficult.
No, excellent point. Let's face it, the Japanese are leading, but the folks involved in Japan in the process, by my observations, are not really focused on the clinical end of things. Nor do they have an FDA that is entirely comparable to ours. That's not to suggest that Japan is free of regulation, but the FDA in many ways is quite unique, and we all understand that nothing goes without the imprimatur of the FDA. Europe, for one reason or another, has been very quiet. I'm not sure exactly what, if anything, is happening in this context, but I must say, as someone who has tried to follow this area, I am still overwhelmed by the Japanese input and very underwhelmed by any other input. So we will have to wait and see where all of this goes. Doubtlessly, at one point in time, this will be a worldwide movement, or at least a worldwide application, if it proves to be successful, potentially more affordable, etc. But as we speak, the center of gravity still seems to be in Japan. And they are not, as I said, terribly clinically inclined, although they are trying to make IVG work in a human, and they will continue to do so. And given their talent, I would predict that one fine day they'll get there. But apart from what we see in Japan, to this day, for one reason or another, maybe because the advantage of the Japanese is such that catching up is hard to do, um, perhaps that's why the efforts are still primarily in Japan. But sooner or later, I have no doubt that in the US, appropriate fruits of this technology will ultimately be brought to bear.
There are 3 startups in the US doing this. So
Yes,
one
there are,
out of
besides,
California and one
yes,
out of New York. Yeah.
right, one in New York and one in California. Absolutely true. Yeah.
There are 2 in California. One's sponsored by one of the Google founders who has a self-interest, and they're very quiet. They haven't published anything, but they do
Right,
exist.
right. But I know these folks have attended the 2.5-day workshop that I chaired in Washington, D.C., and we had the pleasure of speaking with them. So yeah, you're absolutely right. Sooner or later, the American giant will rise, and we will see where we are.
I'd be more concerned the Chinese giant, given that like 40 to 50% of research papers now are coming from China in most journals. So
We'll see.
Yeah.
I don't think I've seen anything on this area yet. It's from China, but as you said, you can't rule it out.
From an ethics standpoint, since you have your feet firmly in the camps of both science and bioethics, what are the bioethicists, who are generally skeptical of a lot of things in reproductive medicine and the way things are handled, what do you think that their general take on this is? Do you sense that there's worry that this could be yet another sort of dangerous tool in our hands? Or do they think that this is something that we'll be able to stay ahead of, rather than, in so many cases, the technology is way ahead of the ethics?
Yeah, Alan, I don't sense any major ethical concerns, if you will. I'm in close touch with the Hastings Institute, of which I am a member, and it is my hope and plan to write a paper with them on this very matter. But when you stop and think about the rationale here, which is essentially a forward-looking, fertility-promoting, positive enterprise, it's a little hard to knock it or to argue against it, even from an ethical point of view. And so while every angle of this will have to be explored, looking at it broadly, it's a little hard to fault a technology that is intended to correct infertility, to bring about enlargement of families and the birth of children otherwise infeasible. So I would be hesitant to go that route, but everything needs to be explored and investigated, and it will. But your point is very well taken.
Thank you. All right, any other questions before we wrap up for today? Okay.
This is a good session.
Yeah.